Hi, this is Dr. Joannides, Chief Medical Director at Optimum Insurance, and this is the Optimum Academy Breast Cancer 101 series, video number 4, Staging and Rating Breast Cancer. So let's get started. So this is part of the Optimum Signature series, and we've included it in the Academy. And on breast cancer, each case is unique and the product of family history, environmental, and other factors. Breast cancer risk factors are nonlinear, meaning that certain risk factors increase the risk more than others. The new Optimum Re breast cancer ratings stratify risk based on the inherent differences in people's riskiness. And we've added a new feature called the risk score, which is unique to our underwriting manual and may be quite advantageous to you as you try to stratify risk in breast cancer cases. So here's some breast cancer statistics. 3.8 million breast cancer survivors were alive in 2019, and they may be still applying for life insurance. So 1 in 8 women will be diagnosed with breast cancer sometime in their lifetime. Approximately 20% of those are in situ cancers, and 80% are invasive. Most, fortunately, are localized with some regional and then fewer metastatic disease, which are obviously the worst possible outcome. And the nomenclature to describe the tissue histology and molecular description in breast cancer is changing. So we'll touch on that in this breast cancer video series. So breast cancer 5-year survival. This is based on the 2019 information. Overall, 91% are alive at 5 years, 84% at 10 years, and 80% after 15 years. So that's a very good outlook. Most are 99% survival for localized breast cancer, 86% for regional, and 27% with metastases. That's why these people are not candidates for life insurance. Early diagnosis is the key, so that's why routine mammograms are useful in detecting disease. They may have been delayed due to COVID-19, and some people are still behind in their scheduled routine mammograms. So what is the basis for which we take a look at candidates for life insurance when they have a history of some sort of breast impairment? So we've talked already in our video series about diagnostic studies and biopsies. Now we're going to be talking about how do we actually rate breast cancer after surgery is done and sentinel node biopsies have been obtained. What's the final outcome of the workup when breast cancer has been diagnosed and people subsequently apply for life insurance? So we've updated our breast cancer manual with the help of consultant Dr. Steve Ragati, who used SEER data. We were able to update our ratings and more accurately titrate the impairment ratings with the excess mortality due to breast cancer. And the ratings are a blend of the stage, the grade, and the hormone receptor status. So important highlights in the Optimum Breast Cancer Manual changes. We did sort of a resetting, and we're basing our manual on underlying concepts rather than using a calculator, since knowledge is power, and we want you to be knowledgeable in how to accurately stratify the risk. The update is a blend of accuracy, competitiveness, and user-friendliness. Will help you find it that it's both user-friendly as well as accurate and competitive with other manuals that you may come in contact with. And we've added this new feature called the risk score, which underscores the hazards of high-grade pathology in the cell grade, the estrogen receptor hormone receptor status, and the HER2 status. The higher the grade, the riskier the case. If ER hormone receptor status is negative, that's a higher risk as well. And if HER2 status is negative, that also adds to the risk. So step one, when you see a breast cancer pathology report, the breast cancer has been removed, you stage it typically using TNM staging, which you are familiar with. So in our manual, we have the typical TNM stages, and this is the T stage based on size. We also have lymph node status, and you'll notice that there's kind of in-betweeners in terms of nodal status with micrometastasis as a P, capital N1, small mi. And so some of these designations for nodal status can get a little tricky, and we're always here to help you hopefully understand and better assess the risk if there's any of these nodal status categories noted. And then, of course, if somebody has metastasis, the M, they're not a candidate for life insurance. So things to be aware of when you're staging breast cancer is that certain stages have more than one TNM category, such as stage 2A has T0 to T1, N1, M0, and also includes T2, N0, M0. So that 2A stage contains both nodal positive cases as well as cases with a larger tumor which are not nodal positive. So, sometimes you have to wonder if these are actually equally risky cases, but this is how the staging categories are, have played out. So this is in the manual, and you can refer to this as needed. So what's this new risk score? If you watched our video number 3, we went into it in some detail, but just to highlight it again, it combines the grade of the tumor. So you get a point for any grade that's regarded as high, poorly differentiated or undifferentiated, or an SBR score of 8 or 9. We'll talk about what an SBR score is. The higher the number of points, the worse the prognosis. So 1 point for that if it's a high grade, 1 point if the ER, estrogen receptor status, is negative or unknown. Don't give a point if estrogen blockers are being used, because they would only be used if the estrogen status was positive. And you get 1 point if the HER2 status is negative. So the risk score may range between 0 and 3. So these are things you can refer to in the manual, which I highlighted in yellow, but it underscores again the importance of the hormone receptor status, which is key. And if you have any confusion, as pointed out in the red arrow here, refer to the MD, or you can ask us about the particular status of the case. I just want to mention that in breast cancer, the risk is nonlinear, meaning that certain factors carry more weight in terms of a higher mortality risk, such as younger age less than 40, large cancers, if there's many nodes positive, if they're ER or triple negative disease is present, BRCA positive cases, if the cells are grade 3, in other words, undifferentiated or poorly differentiated, or if the person just had recent treatment. Those are the high risk cases. So this risk score is based on information provided by this doctor, Dr. Chavez McGregor, who used the AJCC latest edition and noted that there's a lot of subtypes of breast cancer that contribute to risk, but she kind of condensed it into looking at 3 factors, as we noted in our risk score: the tumor grade, the ER status, and the HER2 status. So she kind of condensed it into those three factors, and it was reported in the Journal of Breast Cancer in 2019. And that's what we used in our manual, since it's so useful compared to all the other factors which might be present in the manual of the AJCC, but a little too in-depth for us to contend with. So we're using this risk score, which was made easier by Dr. Chavez McGregor. So just to reiterate, and this can get a little confusing, so even I have confusion at times, so I have to refer back to this. But if you'll notice, with regard to hormone subtypes and risk, when we talked about the risk score points of the Chavez-McGregor risk score, you'll notice that most cancers are in the pink area, about 73%. And the HR stands in this case for estrogen receptor positive. So HR positive, that's estrogen receptor positive or hormone receptor positive, and HER2 negative, that's 73% of breast cancer in the US in 2012 to 2016. And using our new risk score, those applicants would get 1 point because the HER2 was negative. The next largest group is in gray, and that's where there is HR negative, that's hormone receptor negative, which is ER negative, estrogen receptor negative, and HER2 negative. That's 12% of the pack, and that gets 2 points because you get a point for being estrogen receptor negative and a point for being HER2 negative. So that's 2 points. The next group is HR positive, so estrogen receptor positive and HER2 positive, so you get 0 points for that. And the smallest group is HR negative, so estrogen receptor negative, and HER2 positive, so you get 1 point for the HR negative or estrogen receptor negative. So that kind of gives you the distribution of how these breast cancer types fall out, and then how the risk score applies points to this group, to all the groups. So breast cancer 5-year survival rates in HER2 subtypes. So 92% over 5 years for hormone receptor positive, so ER positive, HER2 negative. 89% for HER2 positive, HER2 positive. 83% for HR negative and HER2 positive, and 77% for triple negative. Now about this SBR grading of the cells, that's for Scarf-Bloom-Richardson, or also called the Nottingham histologic grading. And you'll notice the pictures at the bottom showing grade 1, 2, and 3. So the lowest grade has a score of 3 to 5. The grade that's intermediate or moderate has a score of 6 or 7, and the grade 3 or high grade is the SBR score of 8 to 9, and that requires us to apply 1 point in our risk score. So how do you come up with these points? So the points are based on 3 characteristics of the tumor. The nuclear grade, you get 1 point if it looks nearly normal and 3 points if it looks very abnormal. Mitotic rate, you get 1 point for the lowest mitotic rate and 3 points for the highest mitotic rate. And on tubule formation, more tubules is better, so you get a lower score, and fewer tubules is bad, so you get a higher score. So you combine all those points and you come up with a SBR score, and if it's 8 to 9, that's high grade, and you get a point in our risk score for that. There's also something I wanted to mention. It's called the KI67 test. If you see this, sometimes it's mentioned in the pathology report, values that are 15% or higher are considered high Ki 67 scores, and higher values suggest more poorly differentiated cells and a potential for metastasis. So that's like extra credit if you see that on a pathology report, just something to keep in mind. High Ki 67 scores are a worse prognostic factor. So determining the final prognostic group. So let's combine all these things together that we've been talking about through this video series on breast cancer. And I know it's a little difficult to keep all these plates spinning at the same time, but hopefully you've stuck with me and you can review those prior videos as well. But what we're interested in is, number one, what is the stage of the breast cancer using TNM? What is the risk score based on the points? And we just talked about how you get points. It's based on the estrogen receptor status, the HER2 status, and the grade of the tumor. So you get between 0 and 3 points. That's the second column. The third column, based on, is the age less than 50, or the fourth column is the age 50 plus. Then determining what, using the stage, the risk score, and what the age is, you come out with a prognostic group for how you're actually going to rate the breast cancer in any particular case. So what I want to point out for sure is that for, let's say for the stage 1A or 1B, you can see what a difference, circled in green, it makes if the risk score is high, like a 3. So that would be a prognostic group of 4 for people less than 50 years old, and a group of 3 for people 50 plus. Whereas if the risk score is 0 to 1, you would be in group 1 and have a much lower risk and a much lower rating. So the risk score really contributes to the placement of a particular candidate for life insurance and what their rating is going to be. And you can see that applies for the other stages as well. 2A and 2B, it certainly makes a big difference of what your risk score is, and the risk certainly goes up if your risk score is higher in each of those groups. So hope everybody's with me on that. So just to reiterate again, this risk score is really key. It's unique to our manual. I don't think anyone else is using this, but it really is important in terms of stratifying the risk for breast cancer survivors. And again, 0 to 1 point is the lowest risk score, 2 points is the next group, and 3 points is the highest risk group. And I've added details for each of those categories that you can review. So using these to get your final rating is a combination of the prognostic group that we've determined using those tables and the years since completion of therapy, right? So you get your final group, you go to the correct chart for age. So in this case, we're going to use a 45-year-old stage 2A with a risk score of 1. So you notice in the left chart, 2A is highlighted in yellow. It was a 0 to 1 risk score, since it was a 1 risk score. And the age of the applicant was less than 50, so you're in group 2. So then you go to the final table of age less than 50, group 2, and the number of years. It was treatment was completed 3 to 4 years ago. You would go to 3 to 4, and then the red arrow points to what the final rating is. I've blacked it out here since not everybody viewing this video has access to our manual, so we cannot share outside of our client base. So, but if you are a client, then you can just go to our manual and see what that rating would be. So this risk score is really the key. So you almost need to memorize it because it's so key and important in determining where people stack out in terms of their mortality risk. So the points for grade, ER status, and HER2 status. So let's determine what the risk score is here. So it's a medical referral, 45-year-old woman with Nottingham grade 2 breast cancer 2 years ago. So grade 2, that's not grade 3, so you don't get a point for that. No ER status is given, and they're not on any SERMs. So what's a SERM? That's like tamoxifen. And the HER2 status is not given, but they initially received Herceptin for 12 months. They're no longer on it. Okay, you would only receive Herceptin if you were HER2 positive. So the fact that they received the Herceptin, they were positive for HER2, and in that case, you do not get a point. So this person would only have 1 point because the ER status was not known. So the risk score would be 1. Hope everybody's with me on that. So case number 1. A 56-year-old woman with stage 2B disease was treated 5 to 6 years ago, so older than 50 at the time of her diagnosis, with poorly differentiated cells, ooh, that's bad, ER negative and HER2 negative. Okay, so that's sounding bad. She was older than 50, but had stage 2B disease, and let's see how many points would we give. Well, we give a point for poorly differentiated. We give a point because she's ER negative, and we give a point because she's HTR2 negative. So that's 3 points. So 2B circled in green with 3 points, age greater than 50 at time of diagnosis. She's group 5. That's the highest group. Well, it's second to the highest group. So that would be a definite risk. So case number 2, 45-year-old woman with breast cancer, 1.3 centimeters, staged as 1B due to T1, C, N1, M, and it's one of these MIs, like the nodal disease, but MI for micrometastases or micromets to a node, moderately differentiated, underwent bilateral oophorectomy, no ER status noted, HER2 negative with mastectomy and chemo completed 3 years ago. So let's go through this slowly to try to understand it. So it's a small tumor at 1.3 centimeters. So, but she did have this micrometastasis to the node, which is a concern. However, it's only moderately differentiated, so no points for that since it's not undifferentiated or poorly differentiated. It says no ER status noted, but she underwent bilateral oophorectomy. You would only do that if she was ER positive and was at risk or something along that line. So this basically tells us that she was ER positive. So you would consider that as no points for moderately differentiated, no points for the ER status, and she would get 1 point for the HER2 negativity. She had mastectomy and chemo completed 3 to 4 years ago. So you would use all those factors to try to come up with what her final grouping was as a prognostic group, and go from there. So this just reiterates that sometimes estrogen receptor is not present in the medical record, but the client may be prescribed anti-estrogen therapy or undergoes surgical ovarian ablation. These clients should be considered as estrogen receptor positive. So That just helps you remember that you don't get a point if they've had bilateral oophorectomy. So again, this risk in breast cancer is nonlinear, with the things that are most worrisome are the young age, large cancers, multiple nodes, ER or triple negative cancers, BRCA positive and grade 3 or high SBR of 8 or 9, and recent treatment. So here's case 5. 62-year-old woman with DCIS, ductal carcinoma in situ in the left breast, treated 4.5 years ago with surgery on an anastrozole and followed closely with mammography, doing well. So it was ductal carcinoma in situ to start with. She was treated 4 to 5 years ago with surgery and put on a hormonal blocker, anastrozole, and doing well. So we would go to our ductal carcinoma in situ ratings. I've put a green box over it since some of the people watching may not be clients, and we can't share our ratings outside of our client base. But you can see this would be easy to understand and go to the right place in the manual to find the correct diagnosis, and this would be a low risk kind of applicant. Here's a 34-year-old woman with a family history of a grandmother, mother, and 3 older sisters, all with breast cancer. Wow, that's a bad family history. The mother also had ovarian cancer and died less than 40 years old. The grandmother and 1 sister died less than 40 years old with breast cancer. This is a really bad family history with all kinds of things going on. BRCA status not available, and I put in parentheses, do you really need that to know what's going on here? And there's no mammogram available. That's all the information you have. Wow, this is a high risk case. Some companies, have ratings for BRCA status. Not that we have information regarding that here, but you can basically understand that this is a very high risk family for breast and ovarian cancer, and something is going on here. Since this woman has not been worked up, we don't have anything available. I would consider this a very high risk case, and I wouldn't even know where to start to come up with a rating. So this would probably want more information before I could consider this person as a candidate for life insurance. So just to reiterate on nodal status, nodal disease in breast cancer is worrisome. These micrometastases are less concerning, but still a concern. And it can get very confusing when you're trying to figure out where you should place this person in terms of, risk for their breast cancer. So it may be an opportunity to discuss with your medical director or ask us to participate in trying to figure out what exactly is the nodal status in these micrometastases, and do they really contribute an increased risk to that particular case. So we can help. Let us know if you see any of these particular designations like NO parentheses I positive or NO parentheses mole positive, or any of these like NI, MI, micrometastasis. We'll be happy to try to help you figure out where to go in these confusing cases. And in metastases, there is a designation of MO, and then in the parentheses, an LI or 1I, it looks like. Those kind of cases, again, no clinical evidence or radiologic evidence of distant metastasis, but deposits of molecularly or microscopically detected tumor cells circulating in the blood, bone marrow, or other regional nodotissues that are no larger than 0.2 millimeters in a patient without symptoms or signs of metastasis we'd have to think long and hard about what we're actually going to do with that particular case. So these can be very tricky and difficult to understand. So feel free to consult us if need be. So the three-step optimum process, the transformation of breast cancer history to optimum life ratings, is this three-step process. Hopefully it's been clarified for you today. We're going to use the stage, the risk score, which is based on grade and hormone receptor status, and then a final rating using all these factors in combination to give you the customized risk on that particular applicant. And when there's atypical findings like edge cases or breast cancer in young women with a long tail risk or BRCA positive issues, or mammography or digital tomosynthesis that has BIRAD 3 or 4, or you see tight calcification clusters or borderline ultrasounds or MRIs, feel free to contact us for assistance in trying to figure out what to do in those particular cases. So our takeaways are the new breast cancer section. You almost kind of need to read it a few times because it is detailed, but once you get the hang of it, it can be very useful to help you. And you got to basically memorize those 3 reasons for getting a point in the risk score. If you're unsure of things along the line, consult your medical director or let us participate with you, and we'll be happy to help out. So we're here for you on those close calls. If you have any questions, feel free to let us know. And thanks for watching our breast cancer series in the Optimum Academy.